I like the favorites. I like the variances. I like the variance in the sense because I'm glad that MCG is aware that all patients are not the same. And when those variances might be one slight thing that's keeping them then, that's keeping them on that acute level and not being able to transition into a lower level from that, it allows me to be able to speak to that. It's important for me to be able to speak and to give my input on that because that makes a big difference. I'm here with the patient, around on the patient, around with my doc on the patient. I collaborate with my nurses on the floor, and we go back and forth. And so, well, there's a suggestion. Could you do X, Y, Z, this and that and the other? For example, I had a patient that came in and it was CHF, and the patient had an exacerbation and things of that nature. And then I think the nurse was asking for something. Oh, he also was having AFib and it was uncontrolled, and she asked for like physical therapy. No, she asked for the patient to ambulate or something, and I was like, well, let's look at it like safely, because people forget we're nurses too. So first and foremost, if I was at the bedside, I wouldn't move this patient until cardiac has cleared him. So once he's cleared, then I would ask the doctor for PT or put in an order stating that the patient, once the patient's cleared by cardio, could we ask for PT? In my variance, I kind of put a blur there so that the payer knows I'm thinking on this line. Or about the discharge. When the patient comes in, everybody, wherever you came from, you're going back until we can investigate more. MCG allows me to be able to track that. So if tomorrow comes and they say, oh, that person will not be able, needs further evaluation, may needs a lower level to a SNF or things of that nature. Okay, so then on that day, I'm able to note that. So the payer will know that ahead of time. So then that means, payer, could you please assist us in looking for a place on discharge, because this is what we're doing. Because it doesn't really take long. People like to hold you up and all these other things. I'm very straightforward. I'm black and white. There's no gray area. So you know that we're going on SNF level. That was on the 9th. Today is the 15th. The patient's going to be discharged. Do you have somewhere for me to go? So I can also go back and support my documentation and say, on the 9th, I notified you, not to say I'm waiting for you only, but it is your responsibility. My discharge planner has already found us a place, but did you find one? No, you didn't. I'm ready. We're gonna move today, you know. So these things, it just keeps you on task. It's such an awesome way of being able to move efficiently through the day with your patients. MCG is right on point.
It helps me support my argument that you know, we're at day 1.5 of the expected 2-day length of stay, and we still have these maybe an EKG or an echo that are outstanding. In fact, maybe I've looked through the process or the items that have been ordered and it's overlooked. So let's get that on board so that the cardiologist can make an informed decision when he comes to the bedside. I don't have to start from scratch every time I do a clinical assessment. I can, because if you've selected a diagnosis, the information that is there will kind of trigger your thought process, or what your thought processes should be. You know, you're going to look through the documentation to see if they've met the criteria. If he came in with anemia, how frequently are we monitoring the labs to determine whether or not it's improved as a result of our treatment or declined as a result of our treatment? So it's kind of leading us in a direction where we are able to respond to questions that may have been answered. We're supplying information to the insurance carrier to support the visit, and it's kind of leading us in the direction that we would need to go to do that.
We're planning to do all scripts. At this present time, we have 3M, we have AS400, so the MCG is embedded in what we have now, and we have to transfer it over into our 3M to send it out to our payers to get the clinical information. I'm just excited about actually seeing what you have to offer in the future, what's to come. I know that there's a lot of things in motion, a lot of things that are upcoming that's going to help us in streamlining our workforce, branching in the logic systems for communication, streamlining. It's always about that. It's so important. And giving us information about getting our doctors on point and keeping them as an assist, always in respect to. You're an MD, I respect you. To assist, that's all it is to assist. It helps me help him.
This time next year, I suppose we're going to transition into Allscripts.
Yep.
And with the use of Allscripts, it looks like the two systems are going to marry. As it's presented right now, we have an expanded use. We're able to select the diagnosis, look at the recommendations in terms of treatment plans, make our rounding. We do an interdisciplinary rounding, so we can talk about some of the things that we've identified in the system to point out when we're doing the bedside rounding. You know, are they going to order this test? Reaching out to physicians to ensure, you know, different procedures are included in their plan of care. Identifying holes or gaps in the process and bringing that to the attention of the staff nurse and the physician.